All right, everyone seems to be in.
Good to start.
I think
Go
so.
ahead.
Jared, go for it.
Okay, great. So my name is Jared Rouse. I'm one of the vascular surgeons at University of Alabama, Birmingham. I'm one of the young vascular surgeon hosts tonight for the Young Surgeon Section Vascular SVS Journal Club. We're going to be talking about the medical management and revascularization for asymptomatic carotid stenosis, which we all know is the CREST-2 trial, which recently was published. We have some great speakers here with us tonight. We have Dr. Natasha Harajan, who's an assistant professor of surgery, and Dr. Stephen Manick, who's a second-year fellow at Baylor College of Medicine, and a couple of my friends from Cleveland Clinic, Dr. Ali Khalife and Dr. Ahmed Saror, who's going to be giving their sort of alternative perspective and for this paper. We have some great author guests coming today. Dr. Brajesh Kumar Lal, who's a professor of surgery and division of vascular surgery at the University of Maryland. Dr. Vikram Kashyap, who's vice president, department chief of cardiovascular services at Cornwall Health. And Dr. George Howard, who's professor emeritus at the University of Alabama School of Public Health. Once we get started, we ask everyone to stay muted. Please submit your questions to the chat. The moderators will call on you, and we look for a great discussion and lots of good learning tonight. So I'm going to turn it over to Dr. Manick for his portion here.
Okay, I'm going to start first, actually. If someone can stop sharing.
Yeah.
Thank you. All right, everyone. Thank you so much. So thank you for being here. I'm Natasha Hansraj, as already Dr. Rouse introduced me from Baylor. And thank you, everyone, for coming and for inviting us to speak today. So I'll be talking on why CREST-2 had to happen with the focus on intensive medical therapy versus CEA. I have no disclosures. So each year, approximately 600,000 new strokes occur in the United States, with an estimate of $56 billion spent according on medical care, disability, and mortality. Carotid disease accounts for about 7 to 18% of these strokes, and earlier data supported revascularization as a preventative strategy, though this approach carries significant costs. Major advances in medical management have since then reshaped the landscape, paving the way for the CREST-2 trial. So to understand why we are here today, let's first review where we started. The SVS guidelines from 2022 recommended endarterectomy over medical management in patients with greater than 70% stenosis who were still low-risk surgical candidates, i.e. having a life expectancy of greater than 5 years and a 30-day perioperative stroke and death rate of less than 3%. These are based on ACAS and ACST trials that demonstrated that that endarterectomy reduced the stroke and death rates by half compared to optimal medical therapy. And this risk was still reduced at 5% even at 10 years. So this is a similar study, a study from the VA group, which corroborated this data, halving of the rate of the stroke in ENDART patients, demonstrating the benefit. So what has changed since then? In the ACAS trial, medical management consisted primarily of aspirin and individualized risk factor control without a standardized protocol. The ACST trial introduced a more consistent use of antihypertensives. However, the major turning point was when the heart protection study in 2002 demonstrated a 25% reduction in stroke risk with statin therapy. And following this, statins became more widely adopted. And by the end of the ACST trial data collection, approximately 70% of the participants were on statins. If we review the data from 2000 to 2008, we demonstrate a decrease in stroke rates from 2% down to 1%. And this is reflected in various other smaller studies between following that. The Oxford population-based study demonstrated even a lower stroke rate of about 0.34% per year. So with a significant improvement in medical management, particularly the widespread use of statins and ACE inhibitors, the rates of both MI and strokes, which are more relevant here, have declined substantially in patients with atherosclerotic disease. And thus, CREST-2 was designed to incorporate the contemporary stroke prevention guidelines using a protocol-based approach to medical management and monitoring to ensure optimal implementation. The parameters are mentioned here. And so, with a similar evolution in the management occurred in intracranial disease. So, we talk about the warfarin aspirin symptomatic intracranial trial that used standard risk factor control, whereas the SAMPRESS trial introduced an aggressive structured medical therapy. And this shift was transformative. The aggressive medical therapy management group actually demonstrated a reduction of stroke and death rate by nearly half. And this is reflective of the impact of the aggressive medical management change. And just as medical management has changed, so has the endarterectomy. There's been much advances in procedural techniques, anesthesia, and perioperative care, and this has significantly improved outcomes. Data from the VQI actually confirm that ENDARs now carry a very low surgical risk profile. For example, CREST demonstrated a 1.4% risk of perioperative stroke. And a meta analysis actually demonstrated that beyond this perioperative period, the stroke risk decreases down to 0.2 to 0.5% per year. The ACST 10-year data sub-analysis is a reflective of both of these medical and procedural changes. It demonstrates that the endarterectomy reduces the stroke risk by about half compared to the medical management group. However, with the use of statins, this benefit becomes smaller. And so, in other words, while patients are managed medically still have a higher stroke rate than those undergoing endarterectomies, the absolute difference is narrowed because the baseline stroke rates have declined with modern therapy. And so to conclude, endarterectomy reduced the rates of ipsilateral strokes compared to best medical therapy in the ACAS trial. Modern medical therapy has advanced so tremendously that the annual risk of stroke is now less than 1%, narrowing that benefit gap. And so the question asks, for patients with high-grade asymptomatic carotid stenosis, does endarterectomy still provide additional stroke prevention beyond intensive protocol-driven medical therapy? Thank you. I will stop share. Oh, I apologize. Let me stop share here. Okay, I think it stopped sharing.
All right, everybody. I'm Stephen Manick, Senior Vascular Fellow at Baylor College of Medicine. And as Dr. Hansraj alluded to, the advancement in medical therapy has really progressed significantly. And so the CREST-2 trial was looking at two parallel arms for patients with high-grade asymptomatic, greater than 70% carotid stenosis across 155 centers. And the two groups that were examined were intensive medical therapy versus CEA plus intensive medical therapy, and intensive medical therapy versus CAS plus intensive medical therapy. So I'm not going to include the intensive medical therapy on the intervention side, but just note that those patients getting interventions also were getting the same level of medical therapy. And so the question is, with modern therapy, is carotid endarterectomy still the benchmark for preventing strokes in patients that have high-grade asymptomatic stenosis? And here's the primary hypothesis stating that from the authors as they developed the protocol for this study. As far as the trial design, it's looking at patients that are greater than 35 years old with greater than 70% stenosis, as noted by duplex or angiography, plus other criteria to confirm this high-grade stenosis. And these patients were not allowed to have a prior TIA stroke or amaurosis fugax in the last 180 days, again, asymptomatic, and no prior major disabling stroke, unstable angina, or AFib requiring anticoagulation. It was conducted across 155 sites in those 5 countries you see listed there, but the majority of patients were enrolled in the United States. And this occurred from 2014, the date of first enrollment, to the date of last follow-up for this portion of the paper in 2024. The imaging was interpreted at centralized locations, the duplexes in Maryland and the CTAs at the Mayo Clinic to standardize the imaging interpretation. The operators for these two groups were required to undergo a screening and credentialing process to ensure that they were high-level operators. And so for carotid endarterectomy specifically, they had to show that the preceding 50 consecutive cases had a less than 3% stroke or death rate. And for carotid artery stenting, that they had to submit the preceding 12 months of cases with procedural reports detailing how they performed the procedures. So the underlying medical therapy for these patients was intensive. It was standardized, and the two main risk factors that were controlled were LDL and systolic blood pressure. LDL goal less than 70, which was which is a recommendation for patients with high-risk cerebrovascular disease based off of recent meta-analyses, as Dr. Hansrath noted, showing a significant decrease in stroke death rates and major cardiovascular events when that goal of LDL less than 70 is achieved. And similarly, systolic blood pressure, lower blood pressure leads to less events in these patients. And so the goal of this study was to control their blood pressure initially less than 140 or less than 130 if diabetic, but as guidelines changed in 2017 from the American Heart Association, the goal for all these patients was lowered to 130 or less for all patients. Other secondary risk factors that were controlled were non-HDL, less than 100, hemoglobin A1C less than 7, complete cessation from smoking, weight loss based off the initial BMI, and these patients achieving moderate exercise burden 3 times a week. These secondary risk factors were followed by a case manager who called the patients every month and helped them get to these goals. The LDL was controlled first with statins that was up titrated at various time points. And if those patients were on maximal statin therapy, still not achieving this goal, ezetimibe or some of the newer monoclonal antibodies were given to the patients. And these medications, when needed, were given to the patients all free of charge by the pharmaceutical companies. The blood pressure was managed by neurologists who was at each site, and they helped titrate the blood pressure based off of their preference. There was no specific blood pressure regimen that they proceeded upon. So I'm going to talk specifically in mind, that's the background for all the patients. I'm going to talk specifically about the medical therapy versus CEA arm. So in this arm, 1,240 patients were randomized. You see there on the right the characteristics of those patients, which match fairly well with the standard patient population we see for carotid endarterectomies of older people in their 70s, predominantly male, predominantly Caucasian, with the normal risk factors we expect to see, and pretty standard LDL body mass, Rankin scores, things like that. The study was powered for an event rate of 3.6% of stroke or death in the first 44 days and then any stroke thereafter. And it was an intention to treat analysis, so the observers were blinded with a median follow-up of 4 years for these patients. Specific to the CEA arm, there were exclusion criteria of any patient who could not tolerate general anesthesia due to prior severe reactions, patients with severe multivessel or high-grade stenosis of their coronary vasculature, inability to be therapeutically anticoagulated with heparin or bivalirudin, which is obviously necessary during a carotid endarterectomy, and then various anatomical factors, which are the standard things we look at when examining patients for their suitability for an endarterectomy. For the intensive medical therapy, again, both the intervention and the non-intervention groups got the same medical therapy, and this graph here is showing on the left the systolic blood pressure trends in these patients in both groups, and you see a pretty good overlap with no significant difference between the two groups throughout the study, and similarly for LDL. Of note, the majority of the patients did achieve these goals, but it was around 60% for systolic blood pressure and a little higher, around 70% for LDL. And then those other secondary risk factors were also controlled pretty similarly among the two groups you see here. So the outcome of this study was a composite primary outcome, meaning that the patients were looked at for the first 44 days, whether they had a stroke or death within those first 44 days. And then after 44 days, it was an outcome of ipsilateral stroke. This was assessed by the patients if they had any signs or symptoms of stroke, going to the nearest hospital, and then the study coordinators were involved and helped facilitated the imaging to confirm whether or not those patients had a stroke after those first 44 days. And what you see here is that for the medical therapy group, at the 4-year outcome point, it was 5.3% having that primary outcome. And then for the CEA group, 3.7%. You see there within the error, these two groups do overlap. So there is no statistically significant difference between medical therapy and CEA at that 4-year time point. And the absolute risk difference was 1.6%, with a relative risk of medical therapy of 1.43. Breaking it down into those two subsets of the composite primary outcome, looking at the primary outcome, days peri-procedural primary outcome from days 0 to 44, you see similarly an overlap where there's a higher event rate in the patients with endarterectomy that overlaps with the medical therapy. And that value is higher for the carotid endarterectomy group, 1.6%, compared to 0.8% in the medical therapy group, with a risk difference of 0.8% among the two. And then looking at the post-procedural, the 44 days to 4 years primary outcome of whether or not these patients had an ipsilateral stroke. Again, you see no statistical significant difference between the endarterectomy and medical therapy group, where there was a 1.4 annual event rate for the medical therapy, 0.5 for endarterectomy, with a relative risk of medical therapy of 2.6. The authors also looked at the subgroups, as prior studies have identified some patients who may benefit more from carotid endarterectomy than others. They wanted to suss this out in their analysis. And if you see here over on the right, when you break down patients by age, by gender, by the rate, the degree of stenosis, I should say, their comorbidities, their CHAS-VASc, whether or not they'd had a stroke previously, 6 months or more in the past, none of these showed any statistical significance within those specific subgroups. So the discussion here and what's making headlines, I think, about this study is that there was no difference statistically between medical therapy and medical therapy plus carotid endarterectomy in this modern recent study. But the limitations have been a hot topic of discussion. I think the things that have been brought up in discussing this paper are that medical therapy in this instance may not mirror clinical practice. Patients aren't getting calls monthly from a case manager to verify that they're losing weight, exercising, not smoking, and they're not getting pharmaceuticals provided to them free of charge, especially the monoclonal antibodies, which can tend to be expensive. And so that may be an ideal situation that we all strive for, but currently in clinical practice, we all know that that's not the case for all patients. They did select well-trained, high-volume operators, which again is not the real world. There's multiple people of different levels of skill doing these operations, and so it may not be applicable in that sense if you're talking about someone who has less experience with carotid endarterectomy performing the procedure. Also of note, the event rate was small. Again, this was powered for an event rate of 3.6%. And if you look at the tipping point analysis that was done, there was a very small difference where a net change of 7 events in one group or the other would change the result to make it statistically significant. And so relatively low amount of events to make a change there. If you go back, and I'll go back in a second to the graph there, you see that there is a crossover at 1.2 years in terms of event rates between medical therapy and carotid endarterectomy. And so that begs the question, is this going to show after this time point, as we get further out here and these graphs start to separate further, will there be more long-term benefits for these patients that is statistically significant? Thank you.
All right, I'll unmute myself. Thank you so much, Steve, for sharing. So I think we're open to asking any questions. We put in the chat box. Okay. I'll just ask the first question. So, this is for Dr. Malik. How would you, based on these guidelines, how would you interpret this for the future? You know, do you think that this is going to be fewer carotid endarterectomies, better selection, or, you know, I know you mentioned that this may not be the medical management that like is easily implemented in clinical practice, but is that something that we need to be more aggressive towards?
Yeah, I think the conversation with patients has changed quite a bit in light of recent studies and this one in particular. And I think the decision whether or not to do a carotid endarterectomy on an asymptomatic patient with high-grade stenosis is really based on that patient's circumstances. I think you have to look at all these factors and consider, does my patient fall into this study group or not? Is this someone who's going to follow up every month with a provider, primary care, neurologist, case managers, people like that to help guide their therapy? And if so, maybe that patient would not benefit as much from a carotid endarterectomy because they are getting that intensive medical therapy. Whereas if you have someone who's less likely to do so, perhaps preventing a stroke with a carotid endarterectomy would be more beneficial to them. But for me, I think the most interesting part of this is that crossover point of 1.2 years. I know you can't extrapolate the data just by looking at a graph, but it appears that with time, the two graphs should grow further apart in terms of medical versus carotid endarterectomy, and we probably will see some sort of significant benefit in patients on a longer term basis, and that can be a conversation to have with that patient based off their life expectancy. So it certainly changes how I have the conversation with the patient. I don't think you should rush every patient to an ENDART just because they have high-grade stenosis if they're asymptomatic, but there certainly is a lot of information to chew on here and having that conversation with them.
Thank you.
I'd like to ask our guest authors a question, but because we all thought CREST 2 is going to be any of the three you guys can answer would be great. But we thought this trial was going to be the one that answered all the questions, right? Like it was going to show that carotids were great for the right people and medical therapy was, good if you, but why didn't it show this? What's the real punchline? Why didn't it really pan out the way that we wanted it to? Because we have all been waiting, right? Every time you hear a grand rounds or talk about carotid artery disease, we're like, well, CREST 2's out there, CREST 2's out there, CREST 2, right? So why do you think it didn't give us the answer we wanted as vascular surgeons?
Right. Maybe I can take a shot at it. First, I do want to compliment both Natasha and the other presenter. That was very nicely presented. I have had the pleasure, for those of you who don't know, of having Natasha as my resident a few years ago. So I'm very proud of her work that she has done. No randomized trial is designed for the purposes of finding an answer you want. That's the first thing you need to take a step away from. I think a randomized trial is primarily designed because there is uncertainty. So we're going in not knowing what the answer is. That's what makes it valuable. So that's number one. Number two, if anything, when I think back to the time when Dr. Howard's here on the call, and I and the other principal investigators were huddled together thinking about designing CREST 2. This is back in 2012, 2013. We truly believed that intensive medical management is the experimental arm in this study. That was the unpredictable intervention. And there was, of course, as Natasha has clearly described, quite a bit of data suggesting that medical management has dramatically improved outcomes. So if anything, there was an anticipation that medical management would perform far better. And it did perform better. When you look at the hard numbers, just some numbers to keep in mind. ACAS Stroke and death rates, 5% at 4 years for carotid endarterectomy, and 11%, and I'm just rounding off numbers, 11% for medical management. Virtually half, right? And you look at what CREST-2 is demonstrating, it's 3 and 6. Again, rounding off numbers, it's still half. That's what's fascinating. In both forms of treatment, the stroke and death rates dropped by half, and yet the difference between the two treatments remained the same. And not just that, the previous thought process that if anything, if carotid endarterectomy were to continue to be more beneficial than medical management, the crossing over of the Kaplan-Meier curves would be shifted to the right. But in contrast to that, remember in ACAS, they crossed at 2 years and change. And in CREST-2, they're crossing at 1 year and change for both forms of intervention. So those are surprises. So I would say that CREST-2 has humbled us. It has broken a lot of what I would call a drumbeat of belief that medical management has dramatically overcome intervention in terms of stroke prevention. It has certainly improved, but not. The second point I wanted to make was that randomized trials, and at the very least CREST-2, was designed to set standards for medical management, for carotid endarterectomy, and for carotid stenting. It was not designed to reflect what is happening in the community at present. And the same can be said for NASET, and the same can be said for ACAS. Right? So when I hear a critique that, oh, intensive medical management in CREST-2 is not what is currently provided in the community, carotid stenting in CREST-2 is not what is provided in the community, and surgery in CREST-2 is not, well, we've won the game because we have achieved a higher level of standards for all of us to aspire towards. And in the coming months and years, we're going to be describing how we delivered the intensive medical management, how we delivered carotid endarterectomy and stenting, so that perhaps we can emulate out in the community all those aspects of it to, in general, improve standards and outcomes. I'm going to stop there.
Thank you, Dr. Lau. That was excellent, and just a great perspective, because that was going to be my next question: is how are we going to emulate that into the community? Because this is obviously wonderful outcomes, and really very thoughtful, very well matched. Thank you very much. I think we're gonna move on to the stenting part. So we'll have.
If I could add one thing to
Yes,
BK's comments. I think we need to be very cautious in how we interpret it. I've always hated this phrase, a negative trial, and be strongly opposed to saying that there was no difference between the treatments. I think that if you look at the magnitude of the treatment effect, it is really fairly substantial. And again, I agree with the comment that was made that it's very, very dangerous to extend the results beyond 4 years. But to me, I was actually very impressed with the treatment difference that was there. I think the most important information in the trial might be the annual event rate in the medically managed group, which is over almost nearly 1.5% in the CEA trial, 1.3, and is 1.7 in the CASH trial. It's probably running at 1.5% a year, which means that if you go out 10 years, you're talking about having a 15% chance of having a stroke. And people are commenting that these event rates are low. I think having a 15% chance of having a stroke is not an insignificant risk.
One other point that I just wanted to correct was in the post-procedural period, the stroke and death rate between carotid endarterectomy and intensive medical management was statistically different. So once you move beyond the 44 days.
Right. It cut the event rate from 1.3% annually in the medically managed group to 0.5% in the surgical group. So it really almost cut it by 2/3.
I do have a follow-up question
Keep
to
in
that.
mind. Sorry.
Oh, sorry. I was just to follow up to y'all's this discussion, because I think this is really what we all want to hear about, at least in the vascular community. How do you change the headlines though? Because when you read these headlines, right, the CREST 2 came out, and the headlines, at least on the Twitter pages and in the email blurbs, is everything. It's like carotid endarterectomy is not the answer anymore, right? Carotid stenting, which I know we're about to get into, which is a good segue in my opinion. But how do you think that we use that in our practice and sway that information? Because you guys have pointed out clearly that the event rate is different, but it's not showing the glaring statistical significance that gets into the headline.
Well, let me start and let BK follow up. I mean, the primary outcome is the primary outcome because we thought it was the most important characteristic of it. It's a big challenge to do the analysis of a surgical versus medical trial where what you're doing is loading up with events in one group but not the other in the first few days of follow-up. How do you characterize the difference that's important to you and is important to your patients? To me, I do think that the primary outcome was non-significant. We can't say anything other than that. But on the other hand, you can say, speaking to your patients, is it worth you taking a risk of about 1% a year in stroke risk? From 1.5% down to 0.5% during the periprocedural period, in order to cut the rate of stroke during follow-up by about 0.8% a year. And so that's going to be cumulative. And so I do think I'm not saying that the study was significant. It wasn't. But I think the reduction in stroke risk post-procedurally is impressive, at least to me. As a non-clinician, I'll add.
So some things were very clear in the study. And I think George pointed out very appropriately that the primary outcome was not statistically different. A potential conversation with patients could start with the fact that there is no doubt that there is a higher risk for a stroke that continues to accumulate over time. And that Kaplan-Meier curve in isolation for the medical managed group is true and accurate. And that is a risk that the patient will continues to accrue, considering that there is no other new intervention that is being introduced. The second fact is that stenting was offered in CREST 2 to a very specific group of patients. And yes, interventionists were credentialed and as well as surgeons were credentialed, but the lesions that were treated in the stenting arm had specific characteristics. And they're all sort of available in the protocol that was published with the paper. 2 centimeters and shorter lesions, no tortuosity, and so on and so forth. Those criteria were very hard criteria. Anything falling outside of that will benefit from revascularization using some other methodology. And I think that that's the kind of conversation you're going to need both in public fora as well as with individual patients.
Dr. Lal, there's another question from the group, and then we'll jump on to Dr. Khalifa. So one of the questions from the group is that the vascular surgery community, I guess it's still concerning that they tend to brush aside the results of this trial with regards to the CEA outcomes. It should strongly impact practice with regards to CEA for asymptomatic disease. If you'd like to comment on that.
No,
Yes.
again, that
Go ahead.
I saw the comment come in, and that's why I said we need to be cautious in how to interpret a negative trial.
Thank you.
It doesn't say that they're the same. It just says we couldn't prove they were different, a radically different point.
Thank you. Dr. Khalifa, if you wanted to jump in for the stenting part, and then we can continue the conversation.
Yeah, I'm kind of jealous, Dr. Hansraj. Dr. Lal, BK Lal remembered you, but didn't remember me, maybe. But I thank you for the committee for the honor to present among these distinguished panel. And I agree with the organizing committee's approach to presenting this as two separate arms of the trial, because echoing everything that Dr. Lal, Dr. Howard, and the authors have mentioned is we were not putting two interventions face to face. We were comparing medical management against intervention. And from that, I'm going to step back a couple of steps back and re-echo Dr. Hansraj's remembrance of all the big major trials, the randomized trials. And up until CREST-2, there was truly not a good randomized trial to assess carotid artery stenting. And even then, it kind of did not, we were in an era where embolic protective devices were not mandatory, stent technology was evolving, and medical management was also evolving as well. And so the studies mostly showed that carotid artery stenting for symptomatic disease was not favorable, and definitely for asymptomatic disease, it was at a higher risk of periprocedural strokes. So here comes the question, as Dr. Lal said back in the 2010, 2012, of how can we truly study to see an ideal stent, ideal carotid endart versus ideal medical management, plus or minus. And I have the pleasure of introducing Dr. Sarur, one of our PGY4 superstars, who will go over the carotid artery stenting trials and what the CREST-2 arm of that study demonstrated.
Thank you, Dr. Khalifa, for the introduction. My name is Suror, and I'll be presenting the stent arm trial from CREST-2. So the study aim was, this is basically the parallel study to compare transfemoral stenting and optimal medical therapy versus optimal medical therapy. And the background to this arm, again, focus on the recent improvement in best medical therapy, as Dr. Hansraj and Stephen discussed, with some observational studies coding the risk of stroke with asymptomatic carotid stenosis to be less than 1%. This is significantly lower than landmark trials such as ACAS and ACST, in which the best medical therapy had the risk of stroke of 11% in 5 years. And this is significantly lower because we believe that in ACAS, the best medical therapy at the time was aspirin 4 times a day, and ACST, the use of statins was 10% at the start of the trial and 80% at the end of it. And only majority of the people were on low intensity statins. So this is a table that shows a summary of prior landmark trials that included asymptomatic carotid stenting. All these trials were designed as non-inferiority trials to compare transfemoral stenting to carotid endarterectomy. As you notice, actually, the embolic protection device was high in all these trials, but they had to use specific embolic protection devices and specific stents. But I want to note for everyone that the stroke rate from 2004 down to 2016 kept decreasing, meaning As best medical therapy improved, stenting also improved because we had better patient selection. The operator curve increased, and technologies improved in stenting. But stenting was not perfect for everyone. So there's vulnerable population with transfemoral stenting. Females were known to have increased risk of stroke. That was shown in CREST, mainly in symptomatic population. And elderly were known to have worse outcomes. So this study was a one-to-one randomization comparing transfemoral stenting with optimal medical therapy. It was an intention to treat, and initially they wanted to have 620 patients in each arm. I'm going to focus only on the primary outcome for the interest of time, but as Stephen discussed, it was initially discussed as peri-procedural for 44 days that included stroke and death, but from 44 days to 4 years, that was only for ipsilateral stroke. As Dr. Lal alluded, there was extensive exclusion criteria for transfemoral stenting. The lesions had to be less than 2 centimeters. They had to have do not have circumferential calcification, no severe tortuosity, no type 3 arch, and no significant disease in the arch or the common carotid. But it was also left at the discretion of the operator to choose for patient selection, and there was no screening committee process. There was an extensive competency assessment was performed by an interventional management committee. The interventionals were selected depending on career experience and volume of cases for the preceding 12 months. A minimum of 3 cases were reviewed with an average of 10. All FDA-approved stents and embolic protection devices were allowed, and closed stents were encouraged. Cardiologists were the majority of the interventionalists, and vascular surgeons were 13%. As Stephen discussed, this was also the same in this parallel study. The medical management goals were the same and included a lifestyle coach via telephone. What is important for this arm was the antiplatelet regimen for the stenting. So 48 hours pre-procedurally, there was DAP loading with aspirin and Plavix. For 30 days post-operatively, it was DAPT, and long-term it was only maintained on single antiplatelet agent. The results in over here show that in stenting, there was a little bit lower than they expected, 616 and 620. But as you look on the right side of the screen, pretty much both the transfemoral stenting and the best medical therapy were comparable in age, and female representation was adequate. Getting into the results, there were focusing mainly on the peri-procedural, so meaning from day 0 to 44. There were no strokes in the medical management group, and there was 7 strokes and 1 death in the transfemoral stenting group, with a risk of peri-procedural stroke or death of 1.3%. This is where the shift happens post-procedure between 44 days to 4 years. In the best medical therapy, 28 ipsilateral strokes were noted with an annual stroke rate of 1.7%, while in the transfemoral stenting, there were only 7 ipsilateral strokes with an annual rate of 0.4%. This is the most important slide, I think, from the stent arm, and this shows the risk of stroke with stenting rises in the first 30 days, and the graphs cross at 1 year, but with transfemoral stenting, it stays flat, with an absolute risk reduction of 3.2%. But stenting worked also for everyone. It worked for elderly patients. It worked for female. Almost everyone seemed to have benefited in this trial from stenting. And the number needed to treat for transfemoral stenting in this trial was 31, which was pretty impressive. The optimal medical therapy group also showed massive improvement. 40% of the patients entered the study at target control, while by the end of the study, 70 to 80% of the patients were at targeted control rates. So And my takeaway from this is that transfemoral stenting reduced the risk of stroke by 3.2%. But we have to be very careful because CREST was not designed to compare carotid endarterectomy versus transfemoral stenting. It was mainly best medical therapy versus revascularization, and revascularization worked. What is also important to point is that transfemoral stenting showed benefit in previous population that we thought would not benefit from, such as female and elderly patients. But the biggest elephant in the room is TCAR. So we know that TCAR avoids the arch manipulation. It's the only current stenting procedure that you can protect before crossing, and it has exceptionally favorable stroke rate as seen as Roadster 1 and 2. And as we can see here, even in VQI data, TCAR performs relatively better than transfemoral stenting. And as Dr. Bishop has shown us in the past, it has a very favorable learning curve, with most operators need less TCAR to achieve a stroke of less than 1%. But will we ever see a randomized control trial with TCAR versus transfemoral stenting, or even versus carotid endarterectomy? It'll be very hard because of the event rate, the low event rate, with most experts thinking that it will need more than 4,000 patients. So in summary, this was a very well-designed study, and I congratulate all the authors. Revascularization prevents strokes and asymptomatic carotid disease. Although advancement in best medical therapy has improved the annual stroke rate, but it's not reproducible outside of this randomized control trial. It'll be interesting to see what the real world data with best medical therapy is. Thank you.
So, thank you, Ahmed. That was a very nice summary with background and foreground. And I do want to agree with Dr. Lal regarding the last point of saying, not because we can't obtain the optimal medical therapy that we shouldn't use it in a trial. This is a randomized controlled trial. You want to test basically the indication for use, right? You wouldn't trial an EVAR outside of its indication for use. I think when studies show you that systolics, LDL, all of those metrics need to be at a certain value, that's where it needs to be. And that may in the future potentially change health policy. But that data is important to show out there what we need to do. We'll take an interesting question from Dr. Abai. Why is the data completely different between CREST 1 and CREST 2? Older patients and female population. Why do we see that? We saw that carotid artery stents did better with with less than 70, and now we see it doing better.
Yeah, I'll take a shot at it. The first thing I'm going to say is that none of what I'm going to say now is backed up by objective analyzed data. So I try to separate my comments and qualify them accordingly. But there are some obvious differences in the way that carotid stenting was performed in CREST and the way it was performed in CREST 2. Credentialing was very similar. In fact, many of the personalities that participated in helping credential stenters in CREST continued to do so in CREST 2. So there was a lot of continuity there. There were two things that were obviously different that we learned in the span of that 10-year interval between the two trials. Number one, lesion and anatomy selection. In CREST 2, there was not that big an emphasis on it because we didn't know. We were naive. And so restrictions like no long lesions, no more than 190-degree bend, no type 3 aortic arches, no circumferential calcification. These were not known at that time, or at least not very well known. Some of them were suspected. So that's a big difference. Lesion and anatomy selection. And the second big difference was, if you think back to the stent that was used in CREST, there was only one FDA-approved carotid stent at that time. It was the AccuLink, an open cell construct. And so it was a single stent trial. Whereas over in CREST 2, another big difference was that it was open to all FDA-approved stents. And in general, there have been far more closed cell stents planted in CREST 2 than open cell stents planted. Now, we're going to be performing an analysis which will be descriptive in nature because there's no way we'll have the power to compare stroke and death outcomes between these two types of stents. But these are big differences between the way stenting was performed in CREST and in CREST 2.
Thank you, Dr. Lal. I think I've always seen, and even when we study for the boards, the board book says, asymptomatic carotid artery disease is controversial. So when we counsel patients, we tell them that even that is controversial. But, echoing what Dr. Howard was saying, that, if you're 60 with greater than 70% and a 15% risk of stroke over 10 years, that's not insignificant. So, when we talk about peripheral arterial disease, we talk about the systemic illness of, it's not just the SFA lesion, it's just not just the renal artery stenosis, it's not just the carotid disease. Do any of the, again, hypothetically from the panelists, anyone have an idea to kind of echo on the question of Dr. Mills is why would we see after we fixed the carotid endarterectomy 3 to 4 years later a peak in strokes? Is that related to the repair or is that related to an overall systemic medical disease that's affecting intracerebral arch, everything?
Yeah, the honest, well-informed answer is we don't know. We are going to be looking into it. I think George will echo what I'm about to say is that this came as a surprise to us too. This was not a pattern we had observed in CREST with this in the surgical arm of that trial. So we are going to be analyzing the data and trying to understand what happened there. But as George very well put it very well in the beginning, the data is what the data is. George, any other thoughts on that? The late 6 or 7 events?
No, not really. I mean, it's I will say I think the two trials are much more similar than they are different. This is hard to explain without a blackboard. I'm a geek, but basically you've got a significant risk reduction post-procedurally in both studies. You've got a reasonably similar reduction in risk between the medically managed and the surgical groups. In one of the studies, it crossed an arbitrary threshold of 0.05, and in the other one, it didn't. There's a lot more to the interpretation of a study than the single p-value. I guess I'll leave it at that.
And I will remind everybody that we are continuing to follow these patients in a CREST 2 long-term observational study. So more on this in the coming few years.
I will also have a question from Dr. Sen, Indrani Sen, which, with the data you're looking at, are you gonna do a sub-analysis of potentially, calcium burden, hypodensity of the lesions, some of those high-risk features that have been described to correlate more with stroke, whether that correlates with stroke, a higher risk of stroke in these patients?
Yeah, that's a great question. One of the things that we collectively, everyone involved in CREST 2 is very proud of, is that we have in these 2,500 odd patients collected over 15,000 imaging studies of one form, shape, or the other. Some of them systematically collected and others collected incidentally. And all of those are going to be leveraged for more information and to learn more. So the systematically collected images include duplex ultrasonography at baseline and then annually thereafter in each patient. We have B-mode images, and we will be performing geometric and morphologic evaluations and analyses thereof. Both analyzing and trying to draw conclusions regarding stroke risk as well as cognitive dysfunction risk. And we have non-systematically collected CT angiography on the plaques too, in about 1,000 patients, and we'll be analyzing that too.
One more question for me for the authors, Dr. Lal, Howard, and Keshav, is you get a 75-year-old female asymptomatic disease in clinic, good health, greater than 80% stenosis. What are we offering her as panelists? Medical therapy, carotid stent, or carotid endartery?
I think Dr. Kashyap has not had an opportunity. Let's put him on the hot spot.
Yeah. Well, thanks. I get the softball question at the end.
I would say that is the hardest question.
Yeah. And of course, let me just thank Misty.
Dr. Humphreys has her answer, TCAR.
And thanks, Misty, for including me. And really, congratulations to BK and George, who are the investigators that really, as you can see from BK's background, were supersonic in getting this trial off the ground and completed. I think there's a couple of clinical takeaways that I would emphasize for the whole group. None of these results are accomplishable without amazing medical management. And I think as a vascular community, we need to do a better job of ensuring adherence, risk factor modification. And we know already that as a community, as a population, we don't do a great job there. We have population-based studies that show that. We did an analysis in Best CLI, which, by the way, was not funded for optimal medical therapy, but we looked at this and found really a great variation in medical therapy adherence. And then, interestingly, migration in terms of OMT scores over time. So I think that's something that all of us can do a better job of in terms of our patients. I think the other takeaway, and of course, as somebody that has done a fair amount of TCAR, I think this validates that endoluminal therapy for asymptomatic patients, again, asymptomatic patients, endoluminal therapy in the carotid artery is probably safe and beneficial. So that leads to a provocative question on what the next step is in terms of understanding how to use either TFCAS or TCAR in your practice. And then the last comment I'll make is, going back to George's point, I know we've focused maybe at least in social media, et cetera, on the negative trial aspect for the CEA. But I think this really gets down to the heart of shared decision-making with your patient, right? There are going to be younger patients that have a lifetime burden of stroke that will opt for a surgical procedure. And I think that is absolutely acceptable as long as you as the practitioner lay out the data and have them understand what this means, not only from a surgical revascularization standpoint, but also adherence to risk factor modification over the long term. Thanks.
Thank you, Vic, and thank you, BK, for being here. I think there's nothing better than having the authors come and help us with the clinical portion. I, of course, love having George here because I will geek out all the time, and I love going through the nuances of all the statistics. And there's a lot of noise out there about this study. So helping us as young surgeons and helping the young surgeons and our group get through that is really important. I want to thank the Young Surgeons section for hosting. We will be back in February 11th at 6 p.m. Central Time for the JVS Online Journal Club. We'll be shifting back to our standard JVS articles, 2 articles each month. And if you want to sign up to host, the link is in the chat. And thank you again to everybody who came, listened, participated, asked questions. Have a wonderful night.
Thank you for the kind invitation.
Thank you.
Thanks, everyone.